Okay, so welcome everyone. Thank you for coming to our chat seminar today. And to those that don't know, this is our monthly seminar. So thank you again for coming. Today, our keynote speaker is Dr. Fani Deligianni, who is a senior lecturer of computing science at the University of Glasgow. And a bit more about Fani. So Dr. Deligianni's background includes interdisciplinary training in medical imaging computing, advanced computing, neuroscience, electrical and computing engineering from various institutions. Her team develops novel, state-of-the-art computational methods to solve challenging problems in biomedical domain. The core expertise of the group is the development of machine learning approaches to analyze electronic health records, medical images, neurophysiological signals, and human motion. She has a track record of over 80 manuscripts accepted to top journals and conferences with over 5,600 citations. She has received many competitive fellowships and grants, including recently an award from CHAI to develop causal survival models in psychosis. So now it's my pleasure to hand over the mic to Fani. Welcome.
Thanks a lot. Thanks a lot for the invitation and the opportunity to present and have a nice discussion with you. I would welcome a lot your feedback. My talk today, it consists of two parts. And the first part, I'm going to talk about ECG analysis we do here in my lab. And the second part, I'm going to show how this can also link to the causal analysis and analysis we do with collaboration also with the CHAI Hub. So we all know what is an electrocardiogram. We know that it's one of the most common and vital tools for heart monitoring. And we see here an example of a 12-lead ECG, which it shows left ventricular hypertrophy. Hypertrophy is an abnormal thickening of the heart muscle. What we can understand by looking into this left ventricular hypertrophy sample is that in order to do an ECG clinical interpretation, it is required to have a diagnosis at the rhythm level. For example, the doctor should decide whether the ECG shows sinus rhythm or it shows signs of tachycardia and so on. As well as interpret the local morphology level of each individual heartbeat. And here, if we zoom in and we see, for example, a heartbeat, we see that it consists from the P wave, and then we see the QRS complex and the T wave. And this ECG is a clinical spatiotemporal signal. Therefore, it relates to the cardiac cycle, an abnormality in either of those waves and complex. It relates also with the specific abnormality in the cardiac cycle and with also an experienced electrophysiology is able to both locate in time and in space this abnormality. In particular, for the hypertrophy example I show you here, the doctor will not only rely on a diagnosis, but also will rely on accurately segmenting this local morphological waves and quantify the length of those waves in order to estimate specific criteria and decide the level of the abnormality, whether there exists an abnormality and what is the level of this abnormality. So Now in AI models try to help electrophysiologists and help clinicians automate some of this process of interpreting ECG signals. And they have become increasingly advanced and accurate and precise. So we are in the era of the foundational models, in fact, in deep learning. Because they show strong performance across many tasks. So here, for example, one of the state-of-the-art foundational models in ECG classification is the ECG-FM. So this is based on CNN and transformers, is pre-trained using contrastive learning, and is also pre-trained based on a masking strategy. The performance of those models does not only reflect their architecture, they reflect also the diversity of the training data they have been used to train them and validate them. So, for example, for the ECG-FM, they used publicly available data, the MIMIC for the PhysioNet, but they also use other datasets, proprietary datasets that are not available to other researchers and public. Nevertheless, what it has been demonstrated is that you can train an AI model, and an AI model can accurately provide you with a classification. Now, the interesting part is that when we were surprised to see that when we applied the model to perform segmentation, then we resulted in a very poor performance. So the ECG-FM was not able to generalize to other downstream tasks, which is one of the promise of the foundational model. So, and you can see here on the bottom half of the figure, you see the ground truth, which shows which parts of the signal we have a P wave, which parts of the signals we have a QRS complex, and which parts we have a T wave. And you see how much the ECG-FM on the top part struggles to perform this task effectively. The other point we know when we study ECG data, and generally when we study medical data and healthcare data, we know about the bottleneck. So we know that there is billion of records, but there is a heterogeneity on the type of measurements, in particular for the ECGs, for the channels, for the setup. You can have an ECG with 12 leads, you can have an ECG with 6 leads, you can have an ECG with 3 leads, you can have wearables with 1 lead. So there is an extreme heterogeneity on the type of leads that will also affect the performance of an algorithm. And we know that also there is rare conditions, ECGs and general medical data. You have a lot of samples from normal healthy people, and you have fewer samples of abnormalities, and of course even less for rare abnormalities. And the last but not least is the lack of manual annotations. So annotations for these data require clinical experts, very highly specialized, therefore is a very expensive process and very difficult process to do in practice. So that's what AI has to address. So looking specifically for contrastive learning and previous techniques underpinning self-supervised ECG work, we figured out that most of those approaches, they were operating in the record level. So you get an ECG from the patient. So this ECG is 10 seconds long, and you can use a number of different methods to classify this ECG. You can use contrastive learning to classify the ECG and so on. But effectively, those 10 seconds of ECGs, they have a lot of heartbeats. Some of those heartbeats can be normal and some of those are abnormal. Therefore, if you consider only at the global rhythm level, then you lose a lot of fine grain information there. Even if you fix a step window, still you lose quite a bit of the signal, and which implies effectively that then you need far more samples to create those inductive bias you require to train effectively your models. So our idea here, inspired by our knowledge of ECG interpretation, is why we don't get advantage of both the global level as well as the local level. And the other observation, of course, we had is why we don't use soft contrast targets here instead of using just hard targets, contrast targets. And in contrastive learning, the traditional contrastive learning is based on hard contrast targets, where actually either you have similar samples or your samples are dissimilar. But in the global level, we can understand that you can have some bits that are abnormal, some bits that are normal. Therefore, your global level, your record, your 10-second ECG is not necessarily belong to one class or to the other. Therefore, contrasting with other samples, you can't really contrast them as necessarily similar or completely dissimilar samples. So we started this approach with multi-scale representation learning. And the first step for contrastive learning is our augmentation at the global level. So at the global level, we construct two views from a single ECG recording, and we project the signal into the vectorcardiogram domain. So as I said before, 12 ECG is a rich spatiotemporal signal, so it's possible to project it in a 3D and represent as a representation of the cardiac electrical activity. And then we apply clinically constrained augmentation. So we apply small rotations and scaling, and then we back project the ECG, and we added some Gaussian noise. So, and it's kind of important. Those clinical constraints are very important here in order to ensure that the augmentations are realistic. So if you introduce arbitrary distortions, then a normal ECG might start appearing abnormal for an electrophysiology. Therefore, that would create also problems with this augmentation strategy. So the global reasons our strategy is following a straightforward path of we have the augmented ECG, we have an encoder, and then we use this contrasting framework. As I said, we wanted to introduce soft contrast targets. Therefore, we extended the contrast loss to be a weighted version of the traditional loss, which is normally based on a binary targets. And here what those heat maps represent effectively is samples from the mini batch and the relationship they have between them in terms of similarity. So at the bit level, is challenging because we have different spacing between the different heartbeats. And the solution to that for us, it was to incorporate information from a heartbeat peak detector. So and then to project those QRS peak location to exact specific portion of the learned embedding, and in that way to anchor our heartbeat within the signal. Therefore, now combining both our encoding in the record level with our encoding in the heartbeat level, we managed to achieve a multi-scale representation learning. And here I can show you another more detailed view of this framework, where in the top you can see the overall architecture. So you can see both at the global level rhythm contrasting approach, which involves the augmented views and how those are passed to our encoder. As well, you can see on the top how our peak detector helps us to extract morphological specific features at the local level. And at the bottom half of the picture, you see the two downstream tasks we're interested in, which this is classification and ECG delineation, but we're going to talk more about those later. So when we apply the evaluation here, we compared with other methods. As I said, the state-of-the-art for foundational models on ECG analysis is the ECG-FM. So we started, we gave a lot of attention to how well we perform with relation to the ECG-FM. It's a big model, so it has 90 more than 90 million parameters, and is trained on public as well as proprietary data. But the version that is available to researchers are the one for trained on public data. So that's the one we used, and we use two databases. So we use the PTBXL to train our classifier. We have a multi-label classification. So here you see the superclasses as the normal, conduction disturbance, myocardial infarction, hypertrophy, and the SD change. And the signal segmentation is not easy to find detailed and manual delineation of the ECG signal. So we found the LUDP data set, and that's what we used here as a ground truth for P waves, QRS complex, and T wave segmentation. Our classification was effectively a linear probing to determine global context performance. And our segmentation was based on dense segmentation for each point we had based on an encoder-decoder architecture. So we compare with the other models. You see here the classification results. We achieve, I mean, we didn't reach the ECG-FM classification, but we managed to achieve 93% of the performance in terms of F1 scores with far less pre-training data and far less parameters. But the interesting results here were on the segmentation side, where actually the ECM performed very poorly compared not only to our model, but also to other less advanced models. And we managed to outperform the models and show a relatively good segmentation performance here and delineation. So there are several things in progress since we did this work. Evaluating against more models. So there is now new foundational models. We have started looking at those, testing on more data sets, pre-training and testing on mimic data set as well, and vice versa. And also addressing the heterogeneity of the ECG lead setup. As I told you before, this is varying. Ideally, we want a model that is trained on 12 leads and performs relatively consistently on other lead setups. I'm not sure if you have any questions at this moment. Let me try find. Oh, I can see a hand there.
Hi, Fani. Stephen in Edinburgh here. Thanks very much. Very interesting so far. I'm interested in your soft contrastive loss. So if I got it right, essentially what you're telling the model there is that the closest neighbors in feature space, i.e. patients, I'm guessing, they're going to be likely to share the same underlying rhythms or problems. And so you're kind of treating them as proxy positives rather than things to push away, right?
Yes, in a way. So the samples are records. So there are 10 seconds records. And what we try to say here is that at the record level, it's not always a hard contrast that would work well. Because some of the bits are abnormal, some of them are not. So then you can quantify perhaps that by using a soft contrast, a soft target, if you see what I mean.
Yes. So I guess my question is, in terms of sort of how you weight these things, is it the case that, is there an optimal sort of way to weight things that generalize well across different data sets? Or can you learn these weights from the signal itself? How do you weight the soft contrastive terms?
So yes, you're right on that we use some different threshold, and we did some ablation study to see what is kind of the weighting for that. So how well will it generalize to the different data sets? That's perhaps things that we are doing at the moment.
Great. No, very, very interesting. Thank you. That helps. Thank you.
Thanks. Any other question? Okay, then I'm gonna go to the second part of my talk, and then we're gonna have more time for discussion. Okay, so my talk is gonna be about the target trial emulation on the effects of antipsychotics on QTC prolongation and mortality. And this is a collaboration with Sam and Rajiv, who are psychiatrists, and they're also collaborators on our Chai Hub, and they are lead the study on the clinical side. So So both of them are psychiatrists, and both of them, they prescribe antipsychotics to patients. Apparently antipsychotics are quite very they can be very harmful for the cardiovascular system. So what they do is they prolong the QTC, so they prolong the QT interval of the ECG. And we know that this prolongation can, if it exceeds some clinical threshold, it can lead to cardiac arrhythmias and heart attack. Therefore, in some of the patients, they give those antipsychotics. They actually have to monitor their heart. They put patches on them. They put sensors on them, and they follow them in a weekly basis to figure out whether actually they need to interrupt the treatment or not. So very accurate estimation of those QTC values is very important for their work. So that's how we started this study. And then we figured out that we don't have enough data to run this on patients with psychotic medication at the moment. So, but it came to our minds that we have a lot of ECG data that they are all sitting on the mimic, on the publicly available data set. Now there is, there used to be Mimic 3 only, now is Mimic 3 and Mimic 4, as we're going to see. So they came up with the idea that Mimic 4 effectively is ICU patients, and apparently ICU patients also use a lot of antipsychotics to manage delirium and agitation. And then so it came out the question, okay, can we actually identify whether there is a risk to the patient that they use those drugs in ICU, while actually they are also the most sensitive patients in a critical stage of their health. So it came up that there were actually randomized trials doing that before. Those randomized trials, though, they were relatively small in terms of size. And there was a good reasons why we would like to use observational data here to examine more diverse and real-world population. So I guess most of you know the difference between RCT and observational data. So in an ideal world, we would like to have randomized controlled trials and to be able to accurately determine the cause and effect. However, doing that is in the current literature is not always possible. So there is a good reason why you cannot always do it with ICU cohorts. There are ethical reasons not being able to do it for ICU patients that they're in a critical stage of their health. And there is other also studies like, for example, rare cancer disease and cohorts that you don't have enough samples to apply randomized controlled trials. On the other hand, what you do have, you have a lot of observational data. And you have clinical databases, which are massive, and they track patients for many years. And in this case, you have ICU patients where you have very detailed records of their ECG forms, as well their lab exams, their medications, and so on. So then instead of having to rely on randomized controlled trials, then there is a good reason of trying to make the most of the observational data you have there and try to extract reliable causal effects. So what we've noticed by trying to put this study together was that it's not easy to design a reliable causal study based on observational data. And the reason is because you need to have specific conditions applying for those data in order to be able to extract reliably those causal effects. And you might know that some of those conditions are the exchangeability, the positivity, the consistency, and the not inference. So effectively, the treated and untreated groups should be comparable. And that means that we shouldn't have unmeasured confounding factors, which they influence both the treatment choice and the outcome. And then every patient in the study population should have a probability of receiving the treatment. And consider, for example, in the randomized controlled trials, there is a strict inclusion criteria on letting the patients in participating in the study, and then they apply a proper randomization of who can receive the drug, who would receive the placebo, and so on. Then we need to have consistency. So the treatment protocol it should be well defined, and the observed outcomes should correspond to the intervention which has been specified. And of course, you can have spillover effects. So one patient treatment assignment should not affect the outcome of another patient. So as I said before, when you have a randomized controlled trial, most of those assumptions here, they are fulfilled by the early beginning, just by achieving the randomization through these trials. Then you have this unconditional exchangeability. So basically, you start already with a population that is completely matched at the very early of your study. On contrast, when you have observational data, you must somehow monitor and engineer those conditions, and you need to monitor that those are that they are relatively consistent and they're relatively true for your data. So as I said, we started with Mimic 4. We also tried Mimic 3, but there was not sufficient data for Mimic 3. There were not sufficient patients taking antipsychotics and having the QTC measurements. So we moved into Mimic 4, which has far more samples. So we have 90,000 intensive care unit admissions. And the beauty of Mimic is that it's actually a real hospital data set. It's well linked. It's a database, an SQL database. So you have the subject ID will link to the hospital ID and will link with your ICU ID. Therefore, this will be based on those identifiers. You will be able to integrate the laboratory measurements, the medical administration, the diagnosis, and all the charted and clinical events. So our study objectives here, we're having two targets, two outcomes. One was whether we can detect at all whether there is QTC prolongation. So would antipsychotics result in an absolute QTC prolongation here that we know that clinically can result in abnormalities and even have result to mortality. So that was our one hypothesis, and effectively, as we're going to see, the delta QTC was also our mediator. And the other outcome here was time to ICU mortality, or effectively whether the effect of exposure to antipsychotics would actually affect the survival time within the ICU setting. Or even in the simplest form, whether it's gonna whether it causally affects people dying in the ICU. So in many traditional studies, the treated group is defined by whether they receive the drug. But here that creates a problem we figure out, which is coined as the immortal time bias. So, for example, if you have patients that they haven't managed to receive this drug because they died, then automatically that creates a bias between your two populations, your treated populations and your untreated populations. Those that they have received the drug, effectively, they had to survive long enough to get it. Somehow they are already somehow healthier than the others. So comparing those patients wouldn't be fair. So what we did here was we anchored our study with this T0, which was the trigger event. And the trigger event was similar to what you can have with a randomized control trial. It was the diagnosis, the neurological diagnosis that the patient should have the drug. So either because he's agitated or because there is behaviorally has been detected that they have delirium. So we use some very conventional scales, measures that the doctors use in ICU to measure these neurological conditions and decide whether to administer the drug or not. There was a washout period, so which we, of course, we didn't want to have people that they already got the drug before, as that would mix the patients. We wanted to measure the QTC after the 24 hours of our T0 event. And of course, as in any causal study, we had to put the DAG together, which shows how the different confounders influence the measurements, influence our mediator variables as well as our outcome effect. So here, as I said, we had a time zero trigger, which is a moment of clinical indication. Then we have the washout period, which we try to ensure that there is no prior confounding through antipsychotic exposure. Then we have the exposure window, which is the intervention period where the patient gets the antipsychotic, and then you have the outcome extraction, which involves both the measurements of the pre-QTC and the post-QTC. So by applying that then to our population, we started with more than 94,000 unique ICU stays. By the time we restricted to first admission per hospitalization to prevent intra-patient correlation, we had less than 27,000 unique stays. That went down to then we had to make sure that the patients are adults and they have a documented trigger event. And finally, we have to also remove invalid timestamps and ensure that the antipsychotic prescription within the 72 hours washout period has applied. So we had to exclude that as well. So now that was one level, but then when we went to level 5, where we wanted to have also pre and post QTCs, then that eliminated far more patients. So you see, for the Delta QTC, we had only 1,355 unique stays. For the prediction of the mortality, we actually have far more patients there. But from those patients, only 2,800 were exposed, whether the rest, they were actually on the control group. As we saw also already on the tag, and I'm not going to go through the confounders as this is clinically selected. There were general confounders, cardiac confound, metabolic confounders that our clinical team put together for us. So the first step, and here we follow just a traditional way of applying causal analysis on observational data, was to basically estimate the propensity and use the propensity score model to estimate each patient's probability of receiving antipsychotic conditional based on the observed covariates. And then treat patients based on this propensity score and adjust the population. So here the goal was to balance the two populations effectively and to generate this pseudo population where confounding variables are distributed evenly across both treated and untreated patients. So by finding the propensity weighting and applying that, then we would be able to, we were able to rescale those measurements and ensure that the population, the two populations are relatively similar. And what we found was that the exposure was actually creating a significant effect on the delta QTC. So in terms of p-value, so we had a significant p-value there. We also tried the same by using a more machine learning approach. So we started using double machine learning. And we choose that because orthogonality there, and this framework relies on two-stage residual process to estimate causal effects. So the idea here is to adjust for high-dimensional confounders using the machine learning. And its primary mechanism involves modeling both the outcome variable Y here, as well as the treatment variable D. And those it models those as functions of our covariates. So the idea is by estimating the residuals based on those models, then you can enforce an orthogonality from the fact that you regress the outcome residuals on the treatment residuals to partial out the confounders. And in that way, the treatment residuals are uncorrelated with your confounders and on your confounders, and then the models is far more robust to small bias that they come from the machine learning side. Effectively, it lets you plug in different machine learning models, so you can try lasso, random forest, XJ-boost, and that gives you the possibility to go to more high-dimensional spaces and to see also nonlinear relationships. So we tried that, and our first attempt wasn't very successful because we hadn't done the fitting well, but the second attempt was fine, and so as soon as we fitted the models, the machine learning models, then all of them, they showed that they have a significant effect here with relation, again, to the prolongation of the QTC. So what we show here is that the delta QTC is significant. And we can see that again also as a violin plot, and we can see the delta QTC. We have a change from baseline, which is statistically significant. The peak QTC, which is also clinically relevant, because effectively is what will drive people to the lethal arrhythmias, would be how big is the QTC. That was not statistically significant. And we did the same exercise now with the exposure, with the time for hospital mortality. So we did exactly the same pipeline, and we got that the results are statistically significant here. Now, what we tried the time to ICU mortality. We also tried the time to hospital mortality with relation to the exposure to the antipsychotic. So again, that was significant. So then we concluded that we managed to do the target trial emulation, and we successfully managed to convince ourselves that the population are comparable. And the findings we got from there was that the antipsychotic administration for delirium in the ICU is significantly associated with QTC prolongation and potentially with increased hazard for ICU mortality. And when we apply mediation analysis, we figure out that then we didn't have any significant effect, which I believe that means that the AP medication impact on mortality is entirely mediated by the change on the delta QTC and not any other mechanism. So things to do, and that would be interesting to discuss with you as well now. So we want to continue with the double ML survival analysis, and of course we want to run more further sensitivity analysis. So far we used QTC measurements based on the ECG waveforms of the mimic-4. In fact, we actually used the automatic measurements extracted from the waveforms in order to ensure that are consistent. So mimic-4 has QTC estimations, but it doesn't have QTC estimation for every patient we wanted. So, but it does have measurements of the different intervals. So we used those measurements to estimate the QTC. So we want to test our approach with our segmentation and see the differences there. As I said, we do want to go to the double ML survival analysis and hopefully go to actionable prediction model. And we found some work we're looking into. So we found again orthogonal survival learners for estimating heterogeneous treatment effects for time to event data. And these are two-step approaches. So you learn the propensity score, the survival probabilities, and the sensory probabilities, and then you obtain orthogonalized version of the target loss with orthogonal second stage learners. So we try to apply those methods, and those methods they rely also on MLP. So they you can use any machine learning, but actually they do have their relatively simple multi-layer perceptron. So they do rely again on making sure that your MLP will converge with your data where we currently are stuck. And of course, you can. They have the advantage that you have now the learners. You can apply the different learners, so you can have T learners to address the treatment overlap issue. You have C learners for the censoring overlap. You have S learners for the survival overlap. You can have a combination of all those learners as well. I mean, this is another demonstration of how how this methodology work. This is taken from the original paper, and as I said before, defines a binary classification, feed-forward neural network, the softmax activation, and then you estimate the hazard functions via maximum likelihood. Using parametric model parameterization. And the other still we're still working on is actually our setup really addressing the immortal time bias. So the issue, as I said before, with the immortal time bias is that there is a period of time from T0 until the patient receives the antipsychotic, that they cannot die in the treatment group. If they die, they would be in the control group. And this adds more death to the control group and makes the invention seem safer than it actually is. And here the solution, so our solution was either to start follow-up after 24 hours, but this has some disadvantages as well. This makes our funding only relevant to people that survive the first 24 hours of delirium. And there is other solutions apparently where you clone every patient and then you have artificial, you apply artificial censoring on those cloned patients. and then you reweight to fix informative censoring. And I'm very skeptical of this, but that's where we are at the moment. So thanks for your attention, and let's go back to my window so I can see you. Any questions?
Thank you for the talk. Yeah, let's thank our speaker. Thank you. Yeah, are there any questions in the audience? You can just ask, or you can type them in the chat if you prefer.
By the way, I don't know, do you guys use double ML? Have you tried?
Well, I have some experience with that, and I can only speak for myself, and also with our previous group, I think some of my former colleagues, they also work specifically. They're developing double machine learning for panel data, so not the same as survival analysis, but slightly in that direction, I guess.
So any tips? I mean, is it do you think is a method is a better method than for example G computation, or is it just another method, or any insights on that?
I do think it has nice properties, especially for average effects. I'm not so sure if it's the best take for heterogeneous effects, maybe. And that's actually what I wanted to ask you, but then you had this listed in your discussion points as well. But then it also becomes problematic when your sample size shrinks, right? Because I think your treatment group is fairly small, if I remember correctly, by looking at your slides. But maybe at the very least you could do some very light subgroup analysis, right? So splitting, maybe creating 2 or 3 groups. But yeah, I don't think I have any particular recommendations from my side.
Okay.
Maybe somebody in the room.
Just wanted to know whether people have tried any of those methods and more insight. They have any more insight on that? So normally when you apply heterogeneous treatment effects, what is the numbers you think that are healthy numbers? So
well, I have some rules of thumb in my head. So I think it all depends on the sample size you have, right? And I think you can try and detect heterogeneity a little bit within the data you have, right? So that can also tell you something
about the data, yeah. In terms of the heterogeneity, in terms of the confounders, for example, in terms of the, this is what?
Right. So to give you a specific example, because I think you mentioned causal forests already, right? So I think what they do inside is, as they build the tree, because I think that's how they are different from normal random forests, is the splitting rule takes into account, in a way, detecting these heterogeneous groups, right? So that objective there, I think, kind of does that already. So even though, at least from my personal experience, I'm not sure if causal forests per se give really good estimates of case on their own, but I think they can be at least helpful in terms of discovering these heterogeneous groups, I think. That's kind of my intuition there.
Okay, thanks. Sorry, you're supposed to ask the questions, but
and also, I was also wondering. Oh, we have a question. Yeah, Stephen, please go.
Thanks, David. So if I may, thanks, Fanny. Very interesting. So I guess I don't know the double ML side very well, but from my understanding, what you're trying to do is learn to sort of strip out confounders from both the treatment and the outcome, right? Is what you're trying to learn to do. And so maybe you can give me a bit of intuition. What's the best way to evidence that we're learning those relationships cleanly? Because I guess that's when the math breaks down. If you fail to do that, I guess it sort of falls over, right?
Yes, I mean, at which level we're discussing now? Because, for example, the double ML is supposed to be double robust, right? So the idea is that if you manage, if each of those models are okay, then the idea is that still the results are reliable. So they can tolerate a bit of, for example, propensity, perhaps not a perfect propensity correction, if you see what I mean, or not perfect censoring, for example, and so on.
Right. So I guess my question is, so what you're learning to get rid of, or to sort of at least be able to identify confounders, right, in both the treatment and the outcome separately, if I understand.
So the confounders, I guess we have a hypothesis for the confounders, right? So we didn't discover them. It was not really a data-driven discovery of the confounders here. So we have a very rigid clinical hypothesis on which confounders to pick.
Okay.
So we didn't do any, in fact, for our study, we didn't do any discovery of the confounders. We just assumed that those are the confounders based on the clinical input. It's in that aspect, it's a very typical clinical study. If you see, I mean, that's what a clinical study would look like, where people say this is the hypothesis and they do the causal analysis. Right.
Right. And so the relationships you're learning there, maybe that's great. Which relationship did you learn with the double ML?
So if we go back to the double ML, we can share again this.
Not something I'm well versed in. Apologies.
No, that's fine. So if we go again to the double ML, then you see here where you have y is your outcome. So you have your outcome model, and you effectively you learn the outcome model based on your confounders. So your G0 basically models the conditional expectation of the outcome given the exposure and the confounders. And the idea is that you estimate the residuals of both of those models. And therefore, the fact that you uncorrelate your variable from the confounders, that's what makes it orthogonal.
Right.
Does this make any sense?
I think that helps. Thank you.
Okay.
I'll have a deeper read. Thank you.
Thanks. Thanks for your question.
There's also some neat tricks that are slightly, I think, hidden in double ML. So what I think is not talked about often is that there's this idea of crossfitting in double ML. That is, maybe it's fairly obvious for ML people that it makes sense to fit your models and then evaluate them on different parts of the data. But then inside double ML, there is this, even when you fit your outcome and treatment models, you do this cross-fitting to do debias even further your effect estimates, right? I think that's one of the other
Yeah,
I think that helps. Thank you.
Yeah, and for example, for the immortal time bias, that's I think it's independent of the estimator. So even if you have a good estimator, if you have the immortal bias, then that remains in the estimator can help with that respect, if you see what I mean. That's my understanding so far.
Yeah, that I'm personally not sure of exactly. I would need to sit down and think more about that.
Yeah.
Okay. Any other questions from the audience? Okay. Well, thank you again, Fani. What a great talk.
Thanks a lot for the invitation. Have a nice afternoon.
Thank you, everyone.
Bye.
Thanks very much. Bye, everyone.
Bye.